first knowledge sharing session of 2023. It's going to be an awesome time. Yes, I can guarantee that. Thank you for joining. If there's someone that still needs to be here, you know someone that needs to be here to get this vital information, send them the link and let them join now. Thank you for joining. My name is Flora Coker. I am the founder of Encapsulate Healthcare Solutions and convener of Own Your Health. We have a lot to share. I won't take your time. I'm going to hand over now to our moderator for the day, Dr. Orode. Over to you.
Good afternoon, everyone, and welcome from wherever you're joining us from. It's a pleasure to have you here. So we're kicking off the session with a topic from Dr. Yeside Akimbolagbe. All right. So Dr. Yeside is a lecturer, Respiratory Unit, Department of Pediatrics, the College of Medicine, University of Lagos. She's also a consultant pediatrician at the Lagos University Teaching Hospital. She has about 17 years of experience in pediatrics and is currently involved in research and management of children with various respiratory conditions, including asthma. So it's lovely to have you, Dr. Yeside. Please carry on.
Thank you, Orode. I hope you can hear me.
Yes, we can.
Welcome everyone to the program today. We're happy to have you here. So I'd like to know if you can see my slide.
Yes.
Okay. So thank you already for that introduction. Today we'll be talking about asthma in children, which is a very important topic, as it's the most common chronic disorder in children worldwide. Nigeria is not exempt from that. So what is asthma? I'm sure we've all heard that term. And basically, it's a chronic or long-term condition or disease in which a person's airways in the lungs become inflamed, which lead them to become narrow, to swell, and to produce extra mucus. And this makes it difficult to breathe. So a long-term or chronic condition means it's something that the person lives with every day. And when somebody has asthma, it manifests as recurrent symptoms. The symptoms that the person has that come in a recurring way are cough, chest pain or chest tightness, difficulty breathing or shortness of breath, and wheezing, which is simply a wheezing sound or whistling sound, heard when the person is breathing out. And these symptoms may be worse at night or early hours of the morning, which is something that is quite peculiar about asthma. And so how does it occur? It comes about from an interaction between the genes and the environment. And what this simply means is an individual who has asthma has inherited that tendency to have an exaggerated response or hyper-responsiveness to substances. So we're all in a room and it's the person that has asthma who would start coughing or having chest tightness or wheeze when, for instance, palm oil is being fried in the kitchen and the smell comes to the sitting room. So it's a genetic disorder, but unlike other disorders like sickle cell, for instance, where we know the actual point on the DNA where there's a mutation, here we don't know. There are many genes that have been associated with asthma, but what we do know is that it runs in families, and that's what gives us that indication that it's something that has to do with the genes. But then what does it mean? Does it mean everybody who has inherited that gene to have asthma, or somebody in the family had asthma? Does it mean everybody would have asthma? No. So the expression is variable. It can skip 2 or 3 generations. And sometimes the person may have asthma not present in childhood, person may present later in life. So it has to do with interaction between inheriting the gene and now being in an environment where the person now has or comes in contact with the things that would trigger that abnormal response. And so when this person, this individual who has inherited this tendency to react, now comes in contact with some, we call them triggers. So some, it may be something in the environment, it may be a particular situation that occurs, and these triggers may be known or not known. So we're talking about children now. So these triggers, the parents or the caregivers, or if it's an older child, they may not necessarily know what exactly is their trigger. And so what are the common triggers? The common triggers, these are things, like I said, that would, make that person to have this abnormal or exaggerated response, are things like dust. So dust mites, these dust might stay within, especially the beddings, and then, would cause the person to react. So things like mold, animals, so the fur or the feathers from animals, or even their dander. So the dander are just pieces of or particles of skin or dry saliva from these animals. If the person comes in contact with them, then the person can have these symptoms that we've said. So other things are things like cockroaches in the house, or even the dead cockroaches, the particles of the dead cockroaches in the house, the presence of that can trigger this. Pollen from flowers, grass, food, so dairy products, seafood, wheat, nuts, strong smells. So here we have a lot of mosquitoes, we have people spraying insecticide. So chemicals, fragrance, perfumes, air pollution, both indoor and outdoor. So indoor, you have secondhand smoke from somebody smoking cigarettes, or fumes, from, cooking, or generator fumes in Nigeria, where we have a lot of people using generators. Generator fumes coming into the home can cause that. And then outdoor pollution, we have a lot of cars, emitting a lot of carbon monoxide and other gases that are harmful. If children, have come in contact constantly with these substances, then they can trigger asthma in them. So exercise, stress, it can be probably during exams, or you find out that probably when the child goes to a party, running around, jumping on the bouncy castle, a few minutes later starts coughing or having any of those symptoms I was talking about. So emotion, child can be crying or be upset or be laughing and suddenly, start having these symptoms I was spoken about. So weather, so things like thunderstorms, or even during winter when it's cold, or harmattan, cold and the dust during harmattan, both of these can trigger asthma. Hormones, so for older children, some of them start having it when they start having their periods, because it's the hormones that are triggering their asthma. Respiratory tract infections, very important. One of the biggest triggers, especially in children less than 5 years. Usually viral infections, but it can also be bacterial or other microorganisms. Sorry. My slide is not advancing.
Maybe try clicking on this. It's what.
Okay, sorry. So this is just showing, just a picture of what I was talking about before. So any of these things are the common triggers that could trigger asthma attacks in children. So asthma can affect children of all ages. So that's one thing I want us to note today, because a lot of people think babies can have asthma, children under 1 year can have asthma. Children, people of all ages, and children even under 1 can have asthma. In most children, the symptoms are mild, so they may not have symptoms maybe once a year, or very infrequently. We call that intermittent asthma. But for some of them, it may become more severe than that and start interfering with their daily activities. It may lead to life-threatening asthma attacks or flare-ups. So attacks are just periods in which these symptoms that we've spoken about earlier become more intensified and more pronounced. And so another important thing about asthma is that the symptoms are variable. So in an individual, at each point in time, may have all the symptoms we spoke about, may have just one, may have them all of the time, may have some of the time. So even in a particular person, the expression of the manifestation of asthma is so varied, and it differs from person to person. Even identical twins would present, the asthma will present in different ways. And so that's very important to understand, because you would hear people saying, oh, the child has been fine, there's nothing wrong. And then suddenly, so the times when you thought the child was fine, those things, the things that are happening, that we spoke about, the inflammation that is happening, at the microscopic level within the airways, you can't see it. And it's only when he now starts coughing or manifesting those symptoms that you would now be able to pick it up, that this child is, having an asthma attack, for instance. It does not have a cure, because we said it's genetic, and as it is, we don't yet have the genetic, so that we don't have any cure in terms of removing that some gene modification that as yet has been able to help with removing that, that tendency to react, from an individual. So it can still be passed on from one generation to the other. So that would be what would be the cure, to remove that tendency for that person to react. So for now, that has not been discovered, but it can be controlled. And that's what we're going to be talking about mainly today. So there are different types of asthma. The presentation would be too long if we really discuss everything about asthma, but just to note that we're going to be focusing more on allergic asthma, which is the most common type of asthma in children. So there are other types of asthma that don't come through the allergy pathway. Some of them are from somebody being obese, for instance, or you have adult onset asthma that happens in those who are when they're adults, or you have the one that when somebody is being constantly exposed to some irritants, then the person now starts, having these asthma symptoms. So the one we're talking about is the allergic one, where the person responds in response to allergens or those triggers that we've spoken about, and then some mediators of inflammation like eosinophils, IgE, that is what happens in allergic asthma. So to make a diagnosis of asthma, usually it's a clinical diagnosis. In most people, you make a diagnosis, especially in children, you make a diagnosis from the fact that this person is having symptoms of cough, difficulty breathing, chest pain or chest tightness, shortness of breath that come recurrently. So if somebody presents for the first time with these symptoms, it may be difficult to say the person has asthma at that point in time, because it could just be the person has a viral infection, person is wheezing, and then it may be a viral wheeze, you're not really sure. But by the time the person starts having it recurrently, then you can say this is likely to be asthma. And then usually when the person has these symptoms in the absence of a fever. So this can be a bit tricky, because in children under 5, a lot of their asthma is triggered by viral infection. So it may be difficult to differentiate between the person who is having that one that has to do with the allergy, with the family history, the inherited one, as opposed to just being a one-off because of an infection. So if a person has these symptoms, like we said, and there's no fever, usually there's no infection, then it's more likely to be asthma. If there's a family history, so this family history, usually when you ask, most people will say no. But when you go back and ask, do your sister's kids or your brother's kids have asthma? Your father, your mother, your grandparents, great-grandfather, you may need to go, back, forward, linearly to find out along the family tree. You will find that somebody has asthma. So either family history of asthma or other allergies. So the person has a family history, or somebody in the family that has hay fever or allergic rhinitis or allergic dermatitis, where they're always, having rashes at their flexures. So that's at the elbow or behind the knee or around the neck, the dry scaly rash and all that. So you may need to really go and ask those kind of questions to be able to get the family history. So family history of asthma or other allergies. you would start suspecting asthma in that individual. And if the person also has, so if that child also has other allergies, so a child that had eczema as an infant, for instance, or is always sneezing, the nose is always stuffy, always, fiddling with the nose, or scratching the nose, scratching the eyes get swollen, especially when probably maybe during if the person lives in a temperate region where they have during summer, where they have a lot of flowers and all that. So once you notice all that, and then the child now starts having these symptoms that we've spoken about, then you start thinking it's likely to be asthma. And then if the symptoms come at night, so we said nighttime, early morning, that's usually when this child that just wakes up, or even sometimes the child may still be sleeping, but you just see that this child is uncomfortable, can't sleep, is always, coughing, having this breathlessness, difficulty breathing, or even the wheeze, especially at night, then you start thinking that this child could have asthma. So usually for children, especially for children older than 6, you need to objectively confirm. So now, though the person has symptoms, you suspect, then you should confirm and make sure that there is evidence of obstruction. And this is what we do when we do lung function tests. So the lung function tests help us to measure the amount of air the person is able to breathe out after taking a very big breath, and how fast that air passes through. So if there's obstruction, which is what happens in asthma, it will be difficult for the person to breathe out. The amount of air and the speed at which that air will come out will be lower than some predicted value. And then you go on to say this child has an obstructive airway disease, most likely asthma. So the peak flow measurement is done. Will be the next speaker would talk more on that, but that can help us. And then the spirometer is the one you come to the lung function lab and then you do. It can also be done in the clinic, and then you measure, and if it's indicative of obstruction, then you make a diagnosis. Some other things that can help in the diagnosis are things like allergy tests. So you have the blood one or the one you do on the skin. And these help you to, so those allergens, all those allergens we've spoken about, either the food or the ones you inhale, you take a bit of extract of those allergens, especially prepared extracts, and then you inject it on the skin, and then you watch for the reaction. And if the child reacts to the area where it was pricked with that extract, then you say that person is allergic to whatever it was the substance that you injected with. And then, or you could take the blood of the child and then send it to the lab, and then in the lab, the blood is now mixed with some of those allergens that we've spoken about, and then you measure the amount of immunoglobulin E that is produced, and then if it's high, you say that person is allergic to that substance. So chest X-ray is done usually to rule out other things. So we said, so there's a saying we say in medicine that not every wheeze is asthma. So it's not every child that is wheezing that is asthma. A child that has a bronchopneumonia, for instance, can wheeze. So you may need to do a chest X-ray to make sure that it's nothing else, or it's not some structural abnormality that the child was born with that is causing obstruction of the airway that is leading to this wheezing. So this is just showing the picture of the spirometry that I was talking about before, where the child takes a maximal breath and breathes out, and you're able to measure. And then this is the skin prick test, where you can actually, check for the reaction to any of those things that we've spoken about: mold, the cat, the dog, and all that, and then pollen. And then you can see, if the child reacts, then you can see that reaction, and then you can say that person's allergic to that substance. So how do we manage asthma? So before talking about inhalers, of course, that is the bedrock of the management, but there are other things that have to be done. If these are not done, then your inhalers may not even work. So the assessment and monitoring. So this has to do with making a proper assessment in terms of a proper diagnosis. What type of asthma does this child have? What's the severity? And you use the symptoms, how frequent the symptoms are happening, and also how bad the lung function or how good the lung function is. And putting all this together, you're able to say this child has whether intermittent or persistent asthma. So intermittent or mild, moderate, severe asthma. And then that would now help you to, in monitoring the child and in knowing what treatment to do. And because we said, this obstruction that the child has is not a static thing. It depends on how. So if the child is in a time of the year or in a particular, maybe live in a particular environment where the triggers are a lot, the allergens are a lot, then at that point in time, the obstruction may be a lot. And if the child goes somewhere where the child is not exposed to a lot of things, the obstruction may not be as bad. So it's not even in that same individual, it's not static. And that's why you have to keep monitoring, reassessing, and adjusting your treatment as needed. And education is very important because this, any chronic disease where the person has to be involved, there's a lot of self-management in asthma, where the person has to, have a lot of knowledge. So about the diagnosis, what causes asthma, or what we've been talking about, in the last couple of minutes, the person who has asthma should know all these things so that they are better able to either prevent or to control their symptoms when they come. Inhalers can be very complicated. There are so many different types of them. We'll learn about that later. And they need to know how to use these, because even if you give the person a prescription and they don't know how to use it, then of course the asthma can't be managed properly. And then also the asthma action plan. This is a written plan that you give to the person who has asthma to know what to do, when they have symptoms. So you write down their symptoms, write down their triggers, tell them what to do when they have these symptoms, and at what point they should go to the hospital. Everything is written there. The amount of inhaler to use, which inhaler to use when you have an attack, which inhaler to use every day to control or prevent your symptoms. And then when, things get out, you would list, for them what those things that they would have, that they will know that this is not something I can manage at home. I need to call 911 or 999 or go to the hospital, depending on what part of the world you're in. And also the environment. So we said genetics, environment. So if the person is on medication but lives in a house where there's mold everywhere, that asthma can never get controlled. So they need to know how to manipulate their environment and control those triggers. And also, there are also coexisting conditions. We call them comorbid conditions, which can be the cause of wheezing or can worsen symptoms in somebody who has asthma. So things like reflux. So gastroesophageal reflux disease, that's the full term. And what that just means is that there are some people that have reflux. Remember, babies, how, when they were really young, when you feed and the food comes back up. So sometimes you can still have that, in older children. And this food comes back up when they eat and then goes the wrong way, keeps going into the airway and irritating the airway, and they can actually wheeze. So if you don't control that, then the asthma symptoms are not going to get better. And then those who are obese. So that on its own can even be cause of asthma without it even being an allergic one, or it can worsen asthma symptoms in somebody who, has the allergic one. And then medication. So we'll hear about that later. So we have two groups of medications: the relievers, that the one that the person uses when they're having symptoms, and the controllers that they use every day to prevent this hyper-responsiveness, this exaggerated response, this inflammation, which happens on a chronic long-term basis. You will need to control that so that the person would not have the symptoms. So what are the myths? There are a lot, we can't cover all of them, but some of them which we're dispelling here are things like the fact that asthma is contagious or infectious. And that's why you find some people in schools, they don't want their kids, sitting down or playing with a child that has asthma. It's not contagious, it's not infectious. There's a lot of stigma around asthma. And that's why you find some people not wanting to bring out their inhalers to use it when they're in public, because they don't want people to discriminate against them. So asthma is not contagious, it's not infectious. It cannot be treated by steam inhalation or rubbing mentholatum or rub on the child's chest. The child has a runny nose, just a common cold, that may help. But if a child is having these symptoms that I said in a recurring basis, the steam inhalation is not going to be treatment for that. It's not by anybody, because the first thing you hear when you tell somebody they have asthma is that, God forbid, I reject it and all that. It's a curse and all that. So it's not. We've said it's genetic, and at least on the scientific point, which is what we're talking about here, it's not caused by any of that, and they're not addictive. So some people feel if you use inhalers, you get addicted to them and you won't be able to stop using it. That's not true. And oral medications are not better or safer than inhalers. Inhalers are safe and they are better because it goes right to where it's needed. And children with asthma can exercise or do sports as long as they're well controlled on their medication. They can actually do exercise. And asthma is not outgrown. That's a very big one we need to dispel today, though symptoms can get better because we've said some of those things that the child is exposed to as they get older. They have less of those viral infections, for instance, and they're better able to understand, their bodies, and sometimes the body actually gets, how will I put it, because they've been constantly exposed, sometimes the body now sort of gets less sensitized to those things and then the symptoms get better. But that tendency to react that has been inherited is still there. The DNA hasn't changed. So that person still has asthma, even though the symptoms may get better. Thank you. I think my time is up. So I'll hand over back to already at this point. Thank you.
Fantastic. Okay, thank you very much, Dr. Yesterday. It's very exciting, and I'm learning a lot as well. We've had lots of interaction in the chat, and please don't worry if you asked a question and your question doesn't get answered now. It will be, but I'll just pick two. So one of the participants has asked, what would be advised for an asthmatic person who loves exercising since it was listed as a trigger?
Thank you already. So as I mentioned later, like I said, we're talking about children here now. So I said they can exercise, they can do whatever sports they want to do, but it has to be when the asthma has been controlled. So when the child is still having persistent symptoms, persistent asthma, where they're having symptoms every day, every week, every month, at that point you cannot exercise because it will definitely make it worse, and you don't want the child to have a very severe attack. So so you can exercise, but it's at the point where your symptoms have been well controlled, then you can exercise. But then there are some people who do have what we call exercise-induced asthma, where it's only exercise that triggers it for them. So for some of them, there's nothing you can do. All you need to do is you have to give them a reliever medication every time they want to exercise. So they use the inhaler before they exercise, and they're fine. Thank you.
Says, good afternoon. Does persistent use of inhaler or drug for asthma have any negative impact in the system?
Okay, so when you said persistent use, so I assume your question is when it hasn't been prescribed. So if it has been prescribed and a doctor is monitoring the person for response, for side effects, then it shouldn't cause any problems, because then the doctor is monitoring and then would adjust, as needed. But if the person is just using it, unprescribed, it can actually be harmful. The steroids, for instance, can have a lot of side effects, on growth, on, causing things like diabetes, or even adrenal suppression, where the person starts getting obese, and even their blood pressure and all that. So it can be harmful if you're not, well regulated. And even the constant use of the salbutamol, which is the blue one, the Ventolin that most of us are used to, using it, too much can also have a lot of deleterious side effects.
Thank you. Perhaps the participants would like to raise their hand so they can clarify what they meant, so that you can better answer their question, unless they're satisfied. So I think it was someone, you haven't put your name, but your title is Infinix Hot NT. Do you want to add a bit more to your question?
Good evening.
Good evening.
No, I think it's quite clear. I was going to ask the question, and I think it's quite clear, and I understood what she actually meant by the explanation she gave. Thank you very much.
Fantastic. Okay, thank you. All right, thank you very much, Dr. Yeside. We have some more questions, but I'll leave them to the end just so that Fam Callista can begin her own session. All right, so I'm going to introduce our second speaker. She is pharmacist Callista Tayo Arikawe. She's a child of God, a wife, and a mother. She graduated with a B.Pharm degree from the University of Nigeria, Nsukka, in 1998. She has worked in the hospital sector, pharma industry, and telecoms in Nigeria. Several years later, she got registered in the UK as a pharmacist in 2012. She currently works in primary care, being part of the multidisciplinary team that manage long-term conditions such as asthma, diabetes, hypertension, and so many others. It's a pleasure to have you, Pharmacist Callista. Please go ahead with your presentation.
Thank you very much, and I'm just glad to be here, and I just want to welcome everyone who is here. And thank you, Dr. Yeside, for giving that great background. You've made the work so much easier for me now. Okay, I'm a pharmacist by training, and usually when it comes to chronic conditions, medicines are very important. So, which is why I've been invited to do this talk. But I just want to point out that with asthma, it's just like Dr. Yeside said, it's not just medicines which are important. You can also have a bit of lifestyle, like avoiding those triggers, and if the child is obese, to lose weight. But we'll be focusing on the medicines to use in managing asthma. But before we go to that, there are a few challenges even in asthma, and I would want to point that there are not too many of Dr. Yeside around to be able to help every person who has asthma, whether a child or an adult. And also, lots of people haven't got the right education, access to it. They don't even know where to get the information they need to be able to self-manage or help their child manage asthma. And of course, many of people here who already suffer from asthma or have kids that suffer from asthma know that sometimes the cost of the inhalers are very are prohibitive, which means that it's not always easy to afford them. And even when they've been prescribed, even sometimes you can't find the inhalers to purchase when you have the money. But the key ones really is if somebody if there's a prescription for an inhaler and the person has the money to buy it and the person can find it. These two last points, poor inhaler technique and lack of adherence to the prescription, to what the doctor has said for the patient to do, they are the two main challenges we have found in managing asthma long term. And like we've heard, it's chronic, so it's not something that can be cured. So it's chronic. And I know that some people may have been prescribed tablets, salbutamol tablets, and all of that in managing their asthma. Those have their uses. The mainstay for asthma therapy really are inhalers. And I'll just go on to tell us why that is so. As we've heard, asthma is a chronic respiratory disease that affects the lungs and the airways. It's inflammatory in nature. So what the inhalers do is that when the inhalers are properly used, they get directly to the lungs. So unlike when you're taking tablets, which sort of will get to be absorbed in systemically, but with inhalers, when it's properly used, it gets the drugs right to where they're needed, and that is why the doses used are also very small doses. Like if one is taking prednisolone tablets, for example, it's going to be maybe like 5 milligrams, which is quite a high dose. But when it comes to the inhalers, we're using doses we use are a microgram, so they're smaller doses. So I know somebody, so the case so it also limits the incidence of side effects. And what it also means that if somebody is struggling with the inhalers, it gets, it can start working really quickly. So it gets to where it's needed really quickly. So that's why inhalers are the mainstay in treating asthma. When we mention inhalers, the different types of inhalers, but I want us to just look at how the inhalers work. They're not all the same. and this is what we need to just make clear, the different types of inhalers. The commonest one is the blue one, which is a reliever, and most asthma patients would have that. But some have also mistaken the relievers, the blue one, to be the one that manages their asthma long term. But if we listen carefully, we'll be able to see that it is not. So the relievers, the correct name is, they're called them bronchodilators. So they open up the airways, really, that's what they do. And that's why they're really fast acting, and they help to relieve the symptoms really, really quickly. You also have, and that's why for somebody who has asthma, it is advised that they have that on their person all the time, because if anything happens, they're out of breath, they're short of breath, they can quickly reach for it and use it and be able to have a relief from those symptoms. And usually in asthma attack, which is why in an asthma attack, the blue one, which is the reliever, is very, very important. And I just want to just say this now, so that the parents who are here or carers who are here would know what to do when a child goes into that sort of an asthma attack and you're at home and you can use the blue. So sort of get a child to sit up and don't let them lie down, and then get a child to calm down as much as possible. Usually when someone breathes out a couple of times, it helps to calm any person down, and then you can get them to begin to use the reliever inhaler, one puff, and every 30, like Dr. Yesterday mentioned, every person should have an asthma plan. So at this time, you have to follow the asthma the plan that's been written up by your doctor. Okay. And what I always say that if it's not getting any better, please seek medical attention really quickly, because asthma can kill, because it constricts the airways and the person begins to not be able to breathe properly. So apart from the relievers, we also have what we call the preventers. And because we have already heard that asthma is a chronic inflammatory respiratory condition, so these preventers are actually supposed to be used on a daily basis, and because they have to keep the inflammation down. If the inflammation is not controlled, then the airways become narrowed and the person has all the symptoms we've heard about. They're usually used twice a day, and like I said, they help to reduce the inflammation. And it lowers the chance of someone having all those nighttime symptoms, shortness of breath, and all of that. In the market, there are quite a few available in the market. I don't want to go into their brand names, but the generic names, I've written about 3 of them here, which are available in the market. And there's another one which particular ones that we know, but I'll mention them by brand name. The Symbicort and the Foster, they are used, it's like a combination of, they can be used, it's actually called the maintenance and reliever therapy. It's like a 2-in-1 therapy. But because we're dealing with asthma in children, I'm not gonna, apart from kids who are over 12 years, where the asthma is really very bad. Otherwise, this is not used in children. So let's not dwell on this one very much. Okay, and then asthma also comes in various forms as well. Sorry, I didn't do my, okay. So, yeah, so there are different types of inhalers that we have. We have the metered dose inhaler, which is what many people are quite used to. Something like the blue inhaler is a metered dose inhaler, and the other ones are metered dose inhalers. An advantage they have really is that most medicines, it has quite a wide range, and they're easy to carry around, especially if you don't have to use a spacer with it. It also has some advantages, and which is actually why I mentioned that inhaler technique is very important, because it requires a good coordination, which if it's not done properly, then the person ends up not getting the medication where it should go, and then also left with some side effects. Usually, we always recommend people who use the metered dose inhaler should use it with a spacer, and I'll talk about that later on. And also, metered dose inhalers, we have seen that they contain a propellant with the way they work, which is how it sends the medication down into the airways. And with all of what we're talking about now about carbon footprint and all of that, it's been seen that some of them have quite a high carbon footprint. In fact, right now, where I practice, we're trying to get patients to go from using the metered-dose inhalers to using the dry powders. But we'll get to that later. So the next one, I wanted to also play, I wanted to just play a short video of how to use an inhaler, because whether it's a reliever or a preventer, but this is, I would say, it's for older children who don't have to use a spacer. But of course, if your child is able to master how to coordinate, then they can also use it this way. So we'll just have a play of that video. Thank you.
Hello, I'm Omar Osman. I'm a consultant respiratory physician. I'm going to show you how to use what's called a pressure meter dose inhaler, or PMDI. It is also sometimes known as a puffer. Getting your inhaler technique right is very important because it helps you manage symptoms better. It may take a few tries to feel comfortable in your inhaler, but it does get easier with practice. If your doctor or nurse has advised you or your child to use a spacer with your inhaler, watch our other videos on using a spacer. When you first get your inhaler, or if you haven't used it for 5 days or more, you will need to test it. To do this, take the cap off, shake the inhaler well, pointing the mouthpiece away from you, press the canister to up. Yeah, any sprays need to depend upon your inhaler, so do check the instructions. This means it is now ready for use. Some PMDI inhalers have a dose counter. If yours has one, check it is not empty. Now, hold your inhaler upright and take the cap off. Check that there's nothing inside the inhaler mouthpiece. Shake the inhaler well. Sit or stand up straight and slightly tilt your chin up as it helps the medicine reach your lungs. The next steps all happen smoothly in one action. Breathe out gently and slowly away from the inhaler until your lungs feel empty and you feel ready to breathe in. Put your lips around the mouthpiece of the inhaler to make a tight seal. Start to breathe in slowly and steadily, and at the same time, press the canister on the inhaler once. Continue to breathe in slowly until your lungs feel full. Take the inhaler out of your mouth and with your lips closed, hold your breath for up to 10 seconds or for as long as you comfortably can. Then breathe out gently away from your inhaler. If you've been prescribed a second puff, wait 30 seconds to a minute and shake the inhaler again. Then repeat the steps. When you have finished, replace the cap on the inhaler. If you've used an inhaler that contains steroids, rinse your mouth with water and spit it out to reduce the chance of side effects. For more tips on using your inhaler, why not watch our other videos?
Okay, hope that was helpful. Now I'm gonna there's a website actually that we can use. Has a lot of information and education that we have access to on the internet. It's called Asthma Long UK. It's quite good. You can also watch a lot of these videos. I recommend it because I know that there are a lot of things on the internet. So I'm very sure about this one that we are going to see on there is evidence-based and it is of a good standard. Okay. Okay, like I mentioned, so we just...
Sorry, Pharmacist Callista, you're echoing a bit.
Am I? Sorry. I don't know why. Is it better? Hello?
It's okay, just continue so we don't...
Okay.
Have you logged on to a different device or something? You might need to mute on that device or something.
No, I didn't log in.
Okay.
Okay, so the other ones are dry powders. I'm not going to stay long on this one because it's not suitable for young children, but because I know that maybe adults who are here, I just mentioned them, the dry powder inhaler. So their benefits that they have a low carbon emission and they're better for the environment. And if used well as well, they can get medication right to where it's needed in the lungs. But I'm not going to stay long on this one. Okay. So when it comes to getting the medication to the lungs where it's needed, especially in young children, we recommend using a spacer. And I'm sure many people who already have this condition or their kids have maybe used to having these spacers. And the good thing about using the spacer is that it helps to get the right amount of medication to the lungs. And it helps, sometimes when you watch people use their inhaler, a lot of the drug actually goes out through by the side of the mouth and is lost. That means he won't have, the person won't get the benefit of the medication. So using a spacer means that the medicine gets to the right place and there's no waste. And also the side effects of like oral thrush or hoarse voice is more or less eliminated when you use a spacer. I have the video here that shows us how to use that. So we can just quickly watch that before we continue. That's link 2, please.
Calista, maybe you should log out and log in again while we're watching this video.
Okay.
So that maybe that will help with the echoing because it's we can't hear you clearly at all.
Ooh, okay.
Let's try that. Thank you. While we're watching the video.
Spiritual physiotherapist. Using a spacer when helping a child with an inhaler means more benefits down into their lungs. It's great for you. Getting is very important. It may take a few tries to feel comfortable giving the medicine this way, but it gets easier with practice. If you're helping a child use face mask with their inhaler in space, watch our video. There are different breathing techniques a child can use. I'll first show you tidal breathing. If their healthcare professional has recommended single breath and hold technique, we'll show you that next. So use the inhaler, hold it upright, and take off the cap. Check there's nothing inside the mouthpiece. If the spacer has a valve, make sure the valve is facing upwards. Shake the inhaler well. Put the inhaler in the hole at the back of the spacer. If the spacer has a cap, take it off. Ask the child to sit or stand up straight and slightly tilt their chin up as it helps the medicine reach their lips around the mouthpiece of the spacer to make a tight seal and begin breathing in and out. Press the canister on the inhaler once and encourage them to breathe in and out slowly and steadily into the spacer 5 times. If their healthcare professional has recommended single breath and hold technique, here's what they mean. Encourage your child to breathe out gently and slowly away from the inhaler and spacer until their lungs feel empty and they feel ready to breathe in. Ask them to put their lips around the mouthpiece of the spacer. Press the inhaler and slowly and steadily the lungs feel full. Take the mouthpiece of the spacer out of their mouth. Ask them to hold their breath for up to 10 seconds or for as long as they comfortably can. Then have them breathe out gently away from the spacer and inhaler. Finally, if your child has been prescribed a second puff with the inhaler and spacer away from their mouth, wait 30 seconds to a minute and shake the inhaler again. Then repeat the steps. When you finish, take the inhaler out of the spacer and replace the caps on the inhaler and the spacer. If your child is using a small volume spacer, some of them make a whistling sound if they are breathing in too fast. If they're using a large volume spacer like this one, the breathing techniques are the same. With tidal breathing, the spacer should make a clicking sound as they breathe in and out. If your child has used an inhaler that contains steroids, make sure they rinse their mouth out with water or brush their teeth to avoid side effects. Remember, you can get more top tips on helping your child use their inhalers by watching our other videos.
Sorry. Hello? Hello?
Hello. Hi, I can hear you. It's better now. Thank
Okay.
you.
Can we see my screen?
Yes, we can.
Yeah.
Okay. So I'm just gonna go back to where we stopped. Okay, so we've seen how they how to use the spacers. Well, another thing I wanted to talk about is how to keep the inhalers clean. And this is very important because if it's something we're using every day or when it needs to be clean, and we encourage people to clean it at least once a week, especially if the preventer you're using every day. And because it has different parts to the inhaler, you have to make sure you're not washing the metal canister. So you have to bring the canister out, and what you're washing is just the plastic enclosure of the inhaler. So bring it out and like I said, remove the metal canister and just remove the mouthpiece as well. And you can just rinse it in a bit of warm running water and just let it to air dry. That's all you need to do. And then you just put it back into the casing and just make sure you prime it to make sure it's able to release the pops into the air. And also very importantly, knowing how to store your inhaler in some parts of Africa, you can have very high temperatures. So it's not encouraged to keep the inhaler near, this is for the metered dose inhaler, near maybe on the windowsill where the sun can make the temperature really go high, and that could affect it. And that's why we say try to keep it in an optimal temperature. Room temperature is best, not where it gets too hot or too cold. And also try as much as possible to keep it where it's dry so that it's not so getting wet. The bathroom usually is not a good place to keep your inhaler. And of course, we always say to keep medicines out of the reach of children, and so that they don't use it as something to play with. And of course, keep the cap always on your inhaler so that your doesn't accumulate dust and any of that. And I remember that yesterday mentioned the flow meter, so I just want to talk about that as well. The peak flow meter is something that is a device that we use to manage just to gauge how asthma is faring in a sufferer. So how it works is that it just helps to, I'll show us a video, don't know how much time I have, to show us a video of how to use it, but the good thing about the peak flow meter, it gauges how much volume of air that someone has. And people who suffer from asthma, they're also always encouraged to keep a diary of their peak flow, because this is very useful. Usually in an asthma plan, the doctor would have told them, when the volume is this low, then you know that it's getting really bad. So you need to do this or do that. So the peak flow meter is a device that people should have when they suffer from asthma. And if it's used properly with that diary, once there's a change in the airways, the person may not have symptoms, but the peak flow may be able to pick that up really quickly, and the person would know that something is going wrong, and then they will be able to take the right action. Shall we watch the video? I don't know how much time I have left. Is that time for it?
All right. How to take your peak flow?
Yeah. So that's the link for.
There's no sound coming through.
Sorry.
To take your peak flow reading, make sure you're either sitting in a chair or standing up, but always do one or the other. Your peak flow meter has a small arrow and you need to push this right to the top near the mouthpiece. Then hold your peak flow meter like so your fingers are not going over the arrow. Take a deep breath in and then you blow hard and fast into the mouthpiece, like this. Wherever the arrow goes, next to which number, that will be your peak flow score, which you can then plot in your peak flow diary.
Okay. So that just gives us an idea of how to use the peak flow. And like I said, keeping a peak flow diary is a good practice for people who suffer with asthma. And then the last point I just wanted to reinforce is the use of nebulizers. I've had a few people who just think that they should be using nebulizers like taking paracetamol or just without any medical advice. So nebulizers are not the main. They should not be the regular. They should not have regular use in asthma. And before using nebulizers, people should be trained in how to use it and how to maintain it. So the routine use of nebulizers is not encouraged, and because it sometimes when people keep using it, then you don't really know if that the disease is getting worse, and the next thing you know is a really, really severe asthmatic attack, which sometimes can be fatal. So we discourage people from just routinely using nebulizers. And the key thing as well is that seek medical attention if you are not, if you're using, when you think a child is having an attack and you have used the relievers and there's no, it's not working. So seek medical attention in acute attacks if symptoms are not improving. The last one I just wanted to say, I think I forgot to mention that, is that for the preventers, the main side effect is oral thrush and hoarse voice. And we encourage people that use them, and the preventers are the steroid inhalers, that if you're going to use them for the children particularly, and even in adults as well, when they use it, please get them to raise their mouth after using it. But the benefit of using the spacer is that it sort of reduces the incidence of those side effects. But when a child is not using the spacers, because I know some people may not have the spacers, then please let them rinse out their mouth after using the preventer, the steroid inhalers. And that's sort of bit of the end of it. Thank you very much.
Thank you, Francis Callista. Thank you so much. So we have a few questions here. The first one is, are there things I can change in my life to reduce my risk of an asthma attack?
I will say something, and I think Dr. Yesterday also mentioned it. The triggers are particularly important. So if people know what triggers their asthma, like we heard, it could be environmental pollution, it could be pollens, it could be exercise. So if once somebody is able to isolate and know what triggers their asthma, then that is one step away from having an asthma attack.
Okay, thank you.
And of course, using the preventer inhaler, the steroid ones, using them as prescribed every day, that would help to keep the inflammation down, and then the person would not have an asthma attack, all things being equal.
Okay, fantastic. You can also stop sharing. And while you're doing that, I'm going to ask you this question from one of our participants that she says, in pregnancy, are some of the drugs or inhaler hazardous to the fetus? And what can the patient do?
Okay, thanks for that question. It's been seen really at the doses that we give, that inhalers come in, they can be used safely in pregnancy and in breastfeeding women. There's no problem using them.
Thank you very much, Pharmacist Calista. I'm sure there will be more questions towards the end, and we'll take those later. I can see a question from Dele Chinedu. We'll ask your question later so that we can hear from the third speaker, who's going to introduce us to another facet of this topic we're discussing today. So our next speaker is pharmacist Olashade Lawal. She's practiced community pharmacy actively for over 30 years. She's the founder and lead pharmacist at Victory Drugs. She's very passionate about rational use of medicines. She's a fellow of the Pharmaceutical Society of Nigeria, Commonwealth Professional Fellow, Associate Member, Royal Pharmaceutical Society of Great Britain, the Vice Chairman, Association of Public Health Pharmacists of Nigeria. She's involved in myriads of programs about public health. She's advisor to DIC, also Desk Officer Medicine Information Center. She's part of that. She's worked as a volunteer for AIDS Coordination and for Scripture Union Nigeria, the Lagos region, for many years. I'm a witness to that as well. When I was much younger, I used to go to Scripture Union. And she was the African representative on the board of Family Impact for some years. So it's my pleasure to welcome our third speaker, Pharmacist Folashade Lawal. Please go ahead. Is Pharmacist Folashade here? Pharmacist Lawal, yes, she is.
She might be having technical issues. Okay, while we're waiting for her to come back, maybe we can ask Dr. Yeside and Calista some of the questions.
Yes, so Dele Chinedu asked Pharmacist Calista, okay, I think she's already answering the question. Is asthma curable? I think Dr. Yeside kind of hinted at this, so maybe Dr. Yeside wants to answer.
Thank you already. So I had spoken about that earlier, but probably the person joined in a bit late. So we had said that asthma is not curable because the cause of it, which we said is genetic, we've not yet found, that has not been discovered yet. So it's not curable, but it's controllable. And that's why we're talking so much about how to control the symptoms. So the symptoms can become so well controlled that the person doesn't have symptoms anymore. And then it seems like it's cured, but it's not curable. The person can still, have an asthma attack if the person comes in contact with something that will trigger that. So always have that at the back of our heads that it's not curable, but it can be well controlled. Thank you.
Thank you, Dr. Yeside. So I'm going to try again. Pharmacist Lawal, are you ready now? Okay, while we're waiting, there's another question here, which I think Pharmacist Calista has answered in the chat. But please do want to share with everyone, Pharmacist Calista. Fumi asks, okay, she's in.
Sorry, I don't know. My device keeps showing me now. I'm about to change.
All right.
I'm about to change the device. So sorry.
That's okay. Okay. So, Pharmacist Calista, you said, are you ready, Pharmacist Lawal?
Yes, if you will allow me share my slide, I think I'm ready.
Okay. All right. Go ahead. Then we'll take questions later.
Okay. Screen sharing.
Okay, you can share now.
Okay. I'm trying to. So sorry for the mix-up. So Can you see my slide now?
Yes.
Yes. Okay. So good afternoon or morning, evening, wherever you have this. I'm so sorry for the fluctuations in my network. I'm highly delighted to be with us again today. And my role is to highlight what your community pharmacists can do for you in the management of asthma in children. This is because, as we all know, the community pharmacist is usually the first port of call. So my outline runs like this. There'll be a brief introduction, roles of the community pharmacist in asthma management. We'll look at hindrances to performing these roles, how to overcome the hindrances, and we'll take a few take-home points. Thank God that the previous speakers, Dr. Yeside and pharmacist Kalista, they've laid a very good foundation, so I can easily...
Sorry to interrupt.
Yes.
Please, could you adjust your camera a bit so we can see your beautiful face? Perfect. Thank you.
Yes. Okay, thank you. So, yeah, we have heard it again and again that asthma can be controlled, but still many people suffer or die from asthma all over the world. And between 2005 and 2015, the number of people suffering from asthma increased by about 12%. And the increase was more in developing countries to which we belong. Now, I said that about 16% of Black children have asthma. Poorly controlled asthma can lead to permanent lung damage or death. Or healthcare providers, the asthma patient, the family, community, policymakers, all of us have roles to play in the management of asthma. But like I said, this afternoon in your climb, we'll be looking at the role of the community pharmacist or the roles of the community pharmacist. So how can your community pharmacist help you? Your community pharmacist can help to identify suspected cases of yet to be diagnosed asthma. I refer for diagnosis. If you listen very well to Dr. Yeside's lectures, she listed out symptoms to look out for. And sometimes the symptoms are not specific, they're not conclusive. The doctor has to make the diagnosis at the end of the day. So when the patient presents at the community pharmacy, the pharmacist is able to professionally look through the symptoms and make adequate referral. So that takes us to the next thing that we do. We work with other healthcare providers to help your child access the best care. We know what we should do, and then where our intervention should have a break for others to come in. So we work with your doctor, work with the lab scientists, and as many as are involved to make sure that your child accesses the best care. And we're also able to educate the parents or caregivers. Sometimes the patients themselves, even though they're children, some of these patients, their children are old enough to get educated. So we educate them on asthma medications, what are the things that may cause asthma attack, like which she referred to as triggers. And you know they are varied. And for individuals, they also vary. Your trigger might not be another person's trigger. So I have here a copy of an action plan that we can use to help you monitor your asthma. Dr. Yeside talked about it. The plan is usually individualized because every patient is different. But what I want us to notice here is that there's a general guideline here that pointer, and we use a traffic lights. Green means that when your symptoms are within green zone, it means that you are doing well. and you should continue whatever you are doing. She has told us that asthma is lifelong, and that's the truth. So you cannot say you got better and you stopped. Whatever you are doing, just keep at it. And then you're working with your doctor, whatever your doctor says. So the yellow, if you have symptoms in the yellow zone, because your doctor would have taken you through all of that. And when you have your plan, you can bring it to your pharmacist too, so that the pharmacist is part of it, since the pharmacist is closer to you. And then the pharmacist will help you to understand or interpret this action plan and get it better personalized to you. So when you have yellow, you know that there's a caution there. You need to add your reliever medicine. And if you get to red, it means that your doctor has to come on the scene. Then we can also help to address parents' concerns about side effects of asthma medications. Many times, parents dwell so much on the medication, the side effects and myths that they rob the child of the necessary treatment. So we can address that for you. We provide training on how to use inhalers and asthma management. The pharmacist Calista has said a lot about that, but it's good for you to know that you can have hands-on training with your community pharmacist. Then we also make asthma management devices available in the community pharmacy for you to purchase. We work with you to achieve the desired outcome, because the desired outcome is that the asthma is controlled. We don't cure asthma, we control it. So we work with you to ensure that that child's asthma gets controlled. Then we also help you to assess the level of asthma control and make necessary interventions. Sometimes we may need to get you back to your doctor if we notice that there are issues with the control, if we're not getting the desired control. Then there are vaccines also that are needed by patients of asthma to keep them off some conditions that might worsen their asthma if those conditions add on to the asthma. So we discuss that with you and work with you and your doctor to ensure that you get the necessary vaccines. Now, having said that, there are some factors that may hinder us from helping you optimally. And one of them is denial or fear of stigmatization. Like Dr. yesterday said, many people are in denial. They will just not want to admit that that child is asthmatic, it's for my enemy, it's for this and that, and they will not own up. And we've seen a number of that in practice. Mothers would have received that diagnosis and they will come and paint a picture, a scenario that would, suggest that they didn't know. And then in the course of the discussion, you will find out that they had already been told that the child was asthmatic. They will say, no, my child is not asthmatic. No, I think we need to overcome that in the interest of the child. Asthma is not anybody's fault that it happened. And it's not a problem that can spread to others or whatever. So it's better managed. As a matter of fact, those with asthma are usually those with very sensitive airways. Their airways are just, they don't tolerate as much stress as the other people's own or whatever. And generally, Dr. yesterday will bear me witness to this. The gene responsible for asthma is also said to be tied to IQ and all of that. And children are generally usually quite brilliant and intelligent. So there's no need to get to have fear of stigmatization. Then some parents just have poor health-seeking attitude. They would wait until everything has gone very bad before coming up. When that happens, it's difficult for us to help us. We would have loved to. We might just have to refer and pray and hope that the best happens. Other factors might be what I call poor adherence. Poor adherence means that you have agreed with your healthcare provider that this is the way we will go, and then you get back and change it and decide to do something else, maybe intentionally. Sometimes it's unintentional, probably while you were being talked with, you didn't understand and you didn't ask questions and you thought. I always say, please, instead of thinking, just ask, because it's better to ask and be clear. A foolish question is better than a supposedly wise, I believe. So let's ask questions, let's be sure, let's be clear, so that we can work together to help your child. Then sometimes it's economic, and especially if we look at what is happening right now, there's cash-strapped, we have a cash-strapped economy. Even when the economy was not like this, many people in Nigeria access healthcare out of pocket, and that can be a lot of financial burden on the family. Thank God that the federal government is now talking about NHIA, even though it's still in the process, which will allow many more people access to healthcare through insurance. So while we wait for that, the issue for now is that there is economic problems around there. There may be cash-strapped. Another issue we might have is what we call health literacy. Health literacy does not have to do with academic literacy. Sometimes even the most academic person might just decide not to get information about health. So if you have a condition or your child has a condition and you are not getting educated on it, then that is poor health literacy. So sometimes the patients have, they don't even know what medications the child is using. They don't know the name, and that makes it difficult. If you don't know the name, how will we help you? They don't keep the prescription. They might have thrown it somewhere or whatever, or they didn't even collect it. So that makes it difficult for the pharmacist to help. If you listen very well to Dr. Yesterday, she stressed the fact that management is individualized. There's no one cap fits all in management of most chronic conditions, and asthma is part of it. So we cannot say, you cannot go to the pharmacist now and the pharmacist will just do an abracadabra to know what drug to give. So sometimes those are hindrances for us. Now, what can you do to help? It's nice, it's good advice that you have your pharmacist and open up to your pharmacist. Your pharmacist is trained in confidentiality. So you can be sure that your information is safe. So open up to your pharmacist so that your pharmacist can help you as professionally as possible to get the best of the care that you deserve or that your child deserves. And you know, especially mothers, once the child is sick, the mother is 200% sick. So it's better that you also, I mean, we are looking at everybody when we are talking of asthma in children. The mother is also part of the patients indirectly. So you need to maintain a trusting relationship with your pharmacist, and that might help you assess care even when you cannot necessarily afford it. If you have a trusting relationship, your pharmacist can bend, the pharmacist can do so many other things for you, including allow you to have some credit facilities when the need arises. Then you need to keep to your pharmacist as much as possible, because you will need your pharmacist all the way. And seek help properly. Please don't assume, don't wait. Many times we've had cases. There was a day that we had this patient call. The child came down with a very bad attack, no reliever inhaler. The roads were blocked. He attempted going to the hospital. The roads were blocked. We had to get somebody on Okada to run down there with reliever. And thank God that we were able to solve that problem. So please seek help promptly. Don't wait. Share needs and concerns with your pharmacist. Don't just take everything line and sinker. Speak out so that you can be helped. Follow your pharmacist's professional advice. Like I said, your pharmacist also works with your doctor and other care professionals in your own best interest. Get current education or information on asthma from your pharmacist. Your pharmacist will be able to direct you to the right sources. You know, Google, all sorts of things are inside. So it's not just Googling asthma and reading up anything that pops up. Let your pharmacist know about other medications or supplements you wish to give your child, because some medications might trigger your child's asthma or make it worse. For example, this popular drug that you all use for children, ibuprofen, when they have fever, sometimes it might trigger an attack. So unless you are working with your doctor as well who prescribed it, and even if your doctor prescribes it, you have to monitor. Once you notice that the asthma is getting worse, speak out so that we'll know that your own child falls into the category of people that that class of drugs that ibuprofen belongs triggers their asthma. It's just about 20% of them, but your child may be one of them. So we don't want to expose that child to that trigger, except we don't have a choice. So it's good to let your pharmacist know. And not all supplements are useful. In fact, many of the supplements may not help with the asthma when the attack is already there. So it's good to talk with your pharmacist. Let me conclude by saying that your pharmacist is well trained and easily accessible. And so it's a great help in management of your child's asthma. So work with her. Thank you, and God bless you. My references. I hope I was said.
Yes, definitely. Thank you very much, Pharmacist Lawal. It's always a pleasure to hear from you, and exciting talks today from all our speakers. So there are some questions we had in the chat. So Saidat is saying thank you so much, Ma, in the chat. So Mrs. Adetola Ajayi is asking, is everyone susceptible to having asthma? Is it more sneaky? Okay, I'll have to check that question again. Mrs. Adetola, if you're there, there's a part of your question that's not so clear, but I'm guessing Mrs. Lawal can answer the first part. Is everyone susceptible to having asthma?
Well, I won't say yes from the risk factors. Many people, I mean, the risk factors are clear. Generally, there's a genetic undertone, and well, once you identify any of those risk factors that was listed, then that means that you could have asthma, but diagnosis has to be made by the doctor. So if you have symptoms that you think is an asthma, please don't assume that it's an asthma. I'm stressing that because I came across a patient that had been on controller inhaler for 10 years without being an asthmatic at the end of the day. Somebody just told him it was asthma, and he started taking the controller inhaler. Meanwhile, he had what we call left ventricular hypertrophy. And by the time, of course, that was diagnosed, it was already very bad. So please, yeah, it's good to suspect, but don't conclude, just seek help.
Thank you. And then Stella Ekong asks, is there a medical test one can do to ascertain that someone is asthmatic?
I think we'll take that at the end. Let's take that at the end, because yesterday went through that. Let's take that at the end.
All right. So Thank you to Pharmacist Callista, Dr. Yesterday, and Pharmacist Lawal. I'm now going to hand over to the CEO of Encapsulate Healthcare Solutions, Pharmacist Flora Coker. Over to you.
Hi, everyone. Thank you so much. Dr. Orode, thank you. I'm going to be brief. I'm just coming back to say hi and just to say thank you for joining. Thank you for staying tuned and thank you for continuing to engage. And I also wanted to announce that Encapsulate has a new service that we're providing. Let me just share my screen. Yeah. Can everyone see that?
Yes.
There we go. So we have a new service we're providing. It's a blood test service. It's quick and reliable. We have locations in London and Aberdeen. And it's essentially if you are in the UK, you live in the UK or you come from abroad and you need to have blood tests done, we have a new service we can provide for you. It's a paid service, of course. So you can reach out to us via our email address, encapsulatehealth@gmail.com. If you'd like more information or if you'd like to book your test, we have had a few clients already. So that's what I wanted to introduce. And the other thing is our next program will be coming up hopefully in April, date to be confirmed with the speakers. I'll be having a meeting with them soon. And we'll be looking at eye health, looking after your eyes. Yes, very important. So that's what I had to say for today. Please, we're going to pop the link for the feedback form for today's webinar in the chat. You know, I really what's the word? Appreciate your feedback. So please do complete the feedback form. It will not take you up to 2 minutes to complete. The speakers would also appreciate feedback from yourselves on how they've done and the information and knowledge that has been shared today. So please do fill that for us. I believe Dr. Ode will pop that in the chat. So, Dr. Ode, back to you.
Hello, everyone. You know, you can interact with your emojis and your screen in the chat. So take advantage of that. We always love to have an engaging program. So we're going back to Dr. Yesterday, and she's going to finish off with this last talk, looking at some very specific things that you should watch out for example, challenges in clinical settings. So I'll hand over to Dr. Yesterday now. Thank you.
Thank you already. Please, can you allow me to share my slides?
You should be able to. 1 second. All right, try again.
Okay. Okay. So thank you for staying on. I hope we're not getting tired or bored. I'll not take too long on this part. So this is just the concluding part of the presentation. And so we've heard about how to use our inhalers and heard about how the pharmacists can help us in achieving this control, which is the aim of, the management of asthma. And Pharmacist Lawal had spoken a bit about some of the challenges in management. And so similar to what she said in the clinical setting, one of the big problems that we have is the denial of the diagnosis. Because if you don't accept the diagnosis, then there's no way you're going to, accept any education that is given to you, any medications, that are prescribed for you, and all the things we've said, all the advice, you're not going to take it because you don't accept that, that diagnosis is what it is. And so that's a very big challenge. And of course, what also goes with that is also adhering to medication. So we've said asthma is not curable, it's controllable. These are the medications, but the poor asthma control is still very, very rampant and very, very common. And that's why you still see people going to the emergency room. Because when you say asthma is well controlled, then the person shouldn't need to go to the emergency room to get nebulized medication or end up in the ICU. So we have a lot of poor medication adherence, either because people don't understand how to use their medication, they don't, or they can't find them, or they're not using it properly and it's getting wasted if the inhaler technique is not good, or they just forget. So forgetting is one of the biggest. So for those who even have the inhalers, they just forget to use them. So sometimes we have to use a lot of tricks, and especially with children where they're dependent on the mom, or the dad, or the caregiver at home, or the nanny to use these inhalers for them. If everybody is not carried along in the management of this child, then that medication is not going to get to the child. So that's a very big problem that we have. And also another one is the over-reliance on reliever medication. So people are used to using the blue inhaler when they have symptoms, they feel better and they move on. And those symptoms may not even come frequently. So they feel, why do I have to be using an inhaler every day when there's nothing wrong with me? But from what we've spoken about, earlier, we've said it's a chronic state of chronic inflammation. So every day that airway is constantly, getting swollen, getting narrower. And the only time the person will have symptoms when it has almost, completely, the obstruction is almost, complete. So the times when it's just partial, the person is still able to. So people tend to manage with their symptoms. A child can't climb the stairs, he will walk slower to climb it. But that's not what we want. We want you to be able to do what you should do, run up the stairs if you're at the age where you can do that and all that. So especially in Nigeria, a lot of people are more familiar with the Ventolin, and that's all they want to use. And then there's another category of people who are willing, but they can't find it to buy. So that I get calls every day, I can't find it. And it's a very big problem. And then you have to start knowing all the pharmacies around, start calling the medical reps of some of the companies that supply this medication, and they also have to start calling pharmacies around. And then just because of poor awareness, even in health, amongst healthcare providers. So a lot of doctors are not very vast in management of asthma. So these controller medications lie on the shelves, they expire, and of course, the pharmacists and those who bring the drugs in are not, are not persuaded or encouraged to bring in these drugs. So those who really need them end up not getting them. And of course, sometimes drugs are very expensive, and they can't afford to buy them, especially in the public setting where I work. Many times they can't afford to. A child may be using drugs of up to 10,000 a month. And how much, does the parents earn? How many children do they have, and all that? So, that's another big problem. And of course, poor asthma knowledge. So knowledge about all what we said, diagnosis, inhaler techniques, and all that is generally poor amongst patients and healthcare providers. Even your patients who have been coming to your clinic, many times they will still ask you some questions and you'll be wondering, so you have to keep, so this knowledge is not something, it's not a one-off thing. It's something that has to continue to happen, even for the healthcare providers and the patients, because you find out that even a lot of, especially young, doctors, nurses, pharmacists, a lot of them don't know about how to manage asthma. And then, so when you write a prescription, sometimes you send, if you don't teach the patient how to use it, and you assume that the pharmacist is going to teach, they just give the person the inhaler, and the person doesn't use it. You see somebody that say they've been using the inhaler, and they didn't even remove the cap. We've seen that happen before. Or there's somebody that was using the inhaler like a perfume on the body, or not putting their mouth on it, just pressing it into the mouth with the mouth open. So these are some of the challenges that we face. And so we also want to talk about the importance of proper diagnosis. So we've been talking about this all day. So the diagnosis of asthma in children it can be difficult, even for specialists, because many times these symptoms that they have mimic a lot of other things. And in children less than 7, 6, they cannot perform the lung function test that you need to do to confirm. And in some children, even these lung function tests can be normal. So So because of this, you have to actually go out of your way to really ensure that this diagnosis is made. And healthcare providers also don't help. A lot of people shy away from making this diagnosis because they know that the parents are in denial and all that. They wouldn't want to say this, the child has asthma. That's why I said call it by its name. You hear things like wheezy bronchitis, reactive airway disease, so many different names. And of course, if an individual if you've not said the person has asthma, then why would the person be using inhalers every day and doing all the treatments that you should do for asthma? So it starts from making that proper diagnosis and calling it what it is. And that will now help you to be able to classify the severity of the asthma and then offer the kind of the definitive treatment that person needs and the advice for each, what to do for each, depending on the severity, things like asthma action plan and all that. It all starts with making a diagnosis of asthma in the first place. And then also, if a proper diagnosis is not made, then things like I said, assessments, monitoring, using peak flow, all these other things that come with it will not happen. And also adherence. So if the proper diagnosis is made, then you're able to explain to the parents or caregivers what is the cause of this thing. It's not this child's fault. It's not anything anybody did. The child was born this way, and this is what you need to do and all that. They are more likely to adhere to the treatment. And also, it also facilitates prevention, because if you know what it is you are treating, then you'll be able to know what to avoid, the triggers and all that. But when you don't know, you've not said the child has asthma, you just say the child has reactive airway disease or wheezy bronchitis, then why would they be thinking, that it's an allergy and they have to keep away from all those triggers or allergens that we've spoken about before? And so what are the consequences? So if proper diagnosis is not made and proper management isn't done and follow-up also is not done, because follow-up is also very important. A lot of people diagnosis is made, you start them on their inhaler, and then you tell them to come back in 2 or 3 months, and they don't come back. And then the next thing, in another 6 months, the child comes to the emergency room and they start calling you that you have a patient here. And then so because they did not come when they're supposed to come, probably the child has not been doing well over the last 2-3 months, and the medicine needed to be changed. But since they didn't come back, then that was not done. So if all this, like we said, proper diagnosis, management, and follow-up doesn't happen, then of course ineffective treatments will be given, proper management will not be done, and there can be increased risks of drug side effects, because that means you're not following a doctor's advice, you're not even seeing a doctor regularly, you're just using the medication just as you like, and then they won't be able to monitor, because when you come to clinic, these are the things we monitor: whether the child is growing well, whether it's having any impact on the child's height, for instance, or excessive weight gain, or the blood pressure is getting high and all that. And sometimes we may even need to do tests. Sometimes these steroids can actually cause issues with the way other hormones in the body are being produced. And most of these side effects are more with the oral drugs. So if there's lack of proper management and follow-up, then the child will tend to have more frequent attacks, come to the emergency room, and need to use the oral steroids. So the oral steroids are used when you have an acute attack in the emergency room. But because drugs in Nigeria are brought over the counter, a lot of our parents, because you've given them prednisolone before, the next time the child has an attack, they just use it. And they don't bother, even coming back to get a prescription from it, because they can get it up over the counter, and they just use it indiscriminately. And of course, then the child can have more chance of these side effects we're talking about. Of course, if the child doesn't have proper management and follow-up, then frequent attacks would happen, and then frequent emergency room visits, poor quality of life. Every time, the child misses school, poor school performance, even the parents miss work, they can even lose their job because they're always going to hospital because the child is always ill and all that. And another thing that people don't realize is that even if the child seems to be fine, that underlying inflammation that is not being controlled can lead to irreversible. So the important thing about asthma is that the obstruction is reversible. So it's not a permanent thing. Once the child uses the bronchodilator, the airway gets bigger, or uses the steroids, the inflammation gets, the swelling and everything goes down, and the airway gets bigger again. But if a child is now being constantly exposed to all these triggers that we've said, and nothing is done about it, then it can become permanent. That inflammation would not respond to anything again, and then it becomes a fixed airway obstruction. So the child now starts, when the child gets to maybe adolescent, adulthood, the child can actually have chronic pulmonary like COPD, chronic obstructive pulmonary disease, where the inhalers don't help to open up the airway anymore, but the lungs can be damaged, and then the child will have reduced lung function. And some adults that have these conditions have to use oxygen. They carry oxygen tanks all around. So we don't want to do that. And that's why we're, hammering on the importance of this proper diagnosis, management, and follow-up. And of course, there's increased risk of death. So asthma, most of the time, the risk of death is very low, but if proper management and follow-up is not done, then you are more at risk of dying from asthma. So how do we prevent asthma? We've said it's interaction between genetics and environment. So the prevention has to do with, tackling it from these two angles. So we've said the only way we can prevent it is from the genetics side, of course, is if when we get to that point where the genes can be edited and the whatever is causing this tendency to react is eliminated, but we haven't gotten there yet. So what we can focus on is controlling the symptoms and controlling the environment that lead to the frequent attacks or the exacerbations that the person has. So some tips. So we've said avoid triggers. So what are these triggers? We mentioned them, before. And so we have to keep our children away from these things. So obviously, no parent should smoke within the home. Of course, smoking is not even good for the parents themselves, but at least for the sake of that child, you should not smoke indoors. So no, cigarette smoking indoors. Air pollution as much as possible should be avoided. That may not be within your control because it may have to do with something in the environment. Of course, Nigeria, if you check the air pollution index on CNN, for instance, you will see that air pollution in Nigeria is a lot. So you may not be able to do anything about the one in the environment, but at least in your home, you have to try to limit or improve the quality of air that child is breathing, and eliminate allergens. So we've said sometimes you may not know what these allergens are. So what I advise my patients is, we know the things, I've listed them above. All those things that I said are responsible or can be triggers for asthma. Just remove them from your home. Dust mites, mold, pets dropping pet hairs and things like that, or even fluffy furnishings. So you have all these toys or furnishings that bring out little fluff or particles in the air. Any of those things would irritate that airway and cause that response that the child is having. So I find that some people with mold, they don't repair the leaking pipes that's causing the mold or clean the area to actually remove the spores from the walls. They just use something to cover it. They're just thinking of the aesthetic, the molds, the greenish thing on the wall, but forgetting that if you just cover it with a painting or something, the spores are still there, and you can easily still get into the air that child is inhaling. So when it comes to pets, it can be tricky because you have a pet does not necessarily mean that it's the pet that is causing your asthma. So, and that's where allergic skin tests come in, where you can actually find out. So before you start telling the person to let go of their pet and all that, you have to be sure that is actually what is causing, the asthma for that particular child. And we've said for things like for exercise that you can use the blue inhaler before. So your doctor may advise you to do that, to use the inhaler before exercise. And sometimes for those who live in the UK, for instance, or temperate regions where the air can be quite cold, then when the child is outdoors, you may need to cover the nose or the mouth with a scarf or mask. And vaccination. So we said infections can be triggers. So to control infections, we say the children should have all the childhood immunizations that are prescribed for the region where the child lives in. So the vaccination schedule for Nigeria is maybe different from that in the UK or the US or wherever you are. So whatever has been prescribed for children in that region, the child should have those. And then there are some extra ones like pneumococcal, even though they have some of it in the up to 5 years, but they can have extra doses later when they're older. And then the influenza vaccines, which is called the flu shots, is given to at-risk people and the elderly in temperate regions like the UK, for instance, and the US. So that is given during the winter season, and we encourage children to have those. So things like emerging ones like COVID vaccine, of course, every child that has asthma, every adult that has asthma should be vaccinated against COVID. So adherence is a way of prevention. So if you use your drugs as prescribed, then you're not likely to come down with the symptoms of asthma. And of course, we've spoken about this before. There are some conditions that if they are not well controlled, they would also worsen your asthma symptoms. So to prevent asthma attacks, those need to be controlled. So if you have reflux, you may be given anti-acid medication. If you are overweight, you may be asked to, go on a weight loss plan, or the child may need to go on a weight loss plan, which the family should encourage, because the child can't be eating one thing and everybody else is eating one thing. So if you're trying to reduce empty calories and of foods that have empty calories in the home, then everybody should encourage the child to do that. And then allergic rhinitis is also a very important one. So children that have allergic rhinitis, usually that is also another way in which they respond to these triggers that we've spoken about. So their nose gets blocked a lot, they sneeze a lot, and then they have a lot of they can have a lot of mucus coming out of the nose and all that. So it's allergy as opposed to the one from a flu, or from viruses or bacteria. And you may need to take some intranasal steroids for that, or antihistamines. So what are the red flags in terms of what are the things that you should see in a child? So the red zone that Mrs. Lawal showed earlier, in the time when the asthma action plan, where the red zone, so this is what the things we're talking about that the child will exhibit, where you have to go to the hospital immediately. So if a child with asthma suddenly starts getting too breathless, cannot talk, is not able to breathe and cannot even talk, cannot even talk in sentences, or is not even able to eat, then you know that it has become really very bad. Or you've used the blue inhaler or any of the reliever medications and the child is not getting better, then you need to go to the hospital. If just by doing minimal physical activity, not any strenuous exercise, the child is already getting shortness of breath and having shortness of breath, then you know that the obstruction is getting very bad and you need to go. And the child is getting drowsy, very weak, not able to stand or walk, or is even unconscious, or is having barely be able to breathe at all, taking very shallow breaths. And if you try to do the peak flow, cannot even blow at all, or the reading is very, very low, which means there's almost complete obstruction, and you need to, even though you start doing some first aid at home, giving as many puffs as you can, but you must start making your way to the hospital. So in conclusion, childhood asthma, we've said, is not curable, but it can be controlled. But early and proper diagnosis is essential in guiding treatment and preventing complications. And if we have very robust education on trigger avoidance strategies, proper inhaler techniques, and adherence to medication, this will go a long way in helping to control asthma. And so thank you very much for listening. And this is just to show that we want every child to be able to breathe and play and live a normal life, even though they have asthma. Thank you very much.
Thank you so much, Dr. Yesterday, for telling us about some of the red flags, how we can prevent, incidences of asthma attacks. Thanks a lot. So what we're going to do now is we're going to start taking questions. So some of the questions we couldn't take earlier. If you could please type your questions in the chat if you've not already done so. Okay, somebody says, can you have a link to do what? So we're going to take questions. Let me see what someone said. Oh yes, I'm going to talk about that right now. Fumi says, can we have a link to watch again? So that's what I just wanted to say before I tell you about that. So anyway, we're on Facebook, Instagram, YouTube. We've been going for a number of years now. Encapsulate Solutions has been. So you can always catch up on all the previous topics that we've talked about on YouTube, okay? Dental health, mental health. Now we're talking about asthma, quite a number of things, using antibiotics effectively, so many other healthcare issues. You can watch all the past events and even this one on YouTube. They're always recorded. But what I'd like everyone to please do now is open your chat box. So that little box you're seeing at the bottom of your screen. Yes, Stella, I'm going to ask you a question in a second. Please just give me a minute. I'd like everyone to tap on the feedback link. Without your feedback, it makes it more challenging to improve. So please tap on the feedback link and give your feedback. It just takes not more than 2 minutes, okay? So let me see some of the questions we had earlier. Someone said, this was Dr. Yesterday, a question for you. What are some common medications to watch out for, which are triggers that asthma patients should avoid?
Okay, thank you. So Pharmacist Lawal mentioned some of those. So the one that would, because we're talking about children now, so the ones that children would most likely be exposed to are what we call non-steroidal anti-inflammatory drugs. So ibuprofen is one of them. So things like diclofenac, there's a whole big group of them which we would not want children who have asthma to use, or we would like them to avoid. So things like beta blockers, which is used for hypertension, not so common in children, but that would be for adults. So adults should also avoid using those.
All right, thank you so much. And then Mujishola asked, is asthma hereditary?
So we've said a lot about that already. Yes, it can be. So I mentioned that not all asthma is actually allergic. So you have non-allergic and you have allergic asthma. But for children, it's allergic asthma that is the most common, and it's the kind that is hereditary. Like I mentioned earlier, you may not be able to find the direct link to the person. So it may be third, fourth, fifth generation. It may be great grandfather or mother or something. So sometimes, even though you feel you don't have a family history, and because most of those people, they did not have formal diagnosis in those days. So you may need to ask, was there anybody that they were always taking to the hospital because the person wasn't breathing well or something like that? So especially in Nigeria, where we don't, the health seeking behavior is not very good, you may not have that family history, but you would have, somebody that had issues with their breathing that was most likely asthma.
All right. And Stella Ekong, I hope I pronounced the surname right, asks, is there a medical test one can do to ascertain that someone is asthmatic? So I think any of the speakers can take this question, can answer, please. Who wants to answer?
I can say something, then Dr. Yesterday can also buttress that. Usually there's a test that can be done, and it checks eosinophils. So it checks because asthma is an inflammatory condition. So usually if the eosinophil count is high, then it becomes one of the, a GP who is a doctor who is doing the diagnosis will take that into consideration. So it is more of the eosinophils, and then of course the also checking the volume of air the patient, which is where spirometry comes in. Those are the ones I know, but blood test is full blood count to check eosinophil level.
Thank you very much, Calista. So in addition to what she said, so the spirometry is a lung function test that you do, and with that, you also do what you call check for bronchial hyperresponsiveness. So what that simply just means is, as part of the spirometry, you also go on to give the person a bronchodilator, and then you check again and see if there was any response. So if the airway got bigger, the person was able to blow more air after giving a bronchodilator, then if the lung function improves after giving a bronchodilator, then you can also use that. Other things are things like exhaled nitric oxide, which also is a measure of inflammation, just as Calista said. So the person blows and then you measure the amount of nitric oxide, and that helps you to say, look, it's chronic inflammation and most likely person has asthma. But these are things that you would not see readily being done. Even in the UK, before they would refer you to a pulmonologist or a center where you get to do all these tests, it's not every asthma patient that gets to have these done. So many times it's the clinical diagnosis that is used, or just the peak flow. And with that, most of the time you're able to make a diagnosis.
Dele Chinedu asked, how often is asthma misdiagnosed statistically in Nigeria? So statistically, how often is asthma misdiagnosed in Nigeria? Any ideas or insights to that?
Well, I wouldn't want to state what I don't know, but in my experience, I would say probably, more than 7 out of 10 or 5 to 7 out of 10, especially in children. Like I said, many times it's difficult. In adults, they have the classic wheezing and all that, but many children may not even wheeze. So a child that is just coughing and finding it difficult to breathe, you may not be able to know that is asthma. So it's misdiagnosed, a lot of times.
Okay. And I know you were talking about, the importance clinically of calling the condition what it is, not, calling it something else, so that helps with sort of any potential stigmatization issues as well. So that's important for participants to note, I think. So let me see, 1 second, please. Okay, are there any tests that are used to monitor asthma as well?
Yeah, so the same tests that are used to diagnose are also used to monitor. So things like the peak flow, like pharmacist Calista said, a child is given the peak flow to go home with. So they use that to monitor their lung function at home. When they come to the hospital for their clinics or their asthma checks, you also use that to monitor. So you compare it to the last reading. You compare, because there's something called the personal best. So that's the best the person is able to do when they are not having an attack. And then that is what you use. So when it's less than that, then you know that this asthma is not getting, better. So spirometry is also done at intervals, maybe once a year, depending on the severity of the child's condition. So you want to monitor after you've started your medication. You want to know if the lung function has improved, if the obstruction has been relieved, and if the lung function is now normal. So so spirometry can also, and also things like the exhaled nitric oxide also would also be used in monitoring.
All right, so we're opening the panel now to the audience. If you have a question, please feel free to to raise your hand, and then we can give you access to ask your questions. All right. So if you don't want to type in the chat, please feel free to raise your hand using the function in Zoom, and you'll be given permission to ask your questions live. Okay. Are you shy? Don't be shy. Yes.
Bumi, I think you had a question in the chat. So just pop your hand so we can unmute you, or you can unmute and ask your question. I saw your name flash in the chat when you were asking the question. I know I've put you on the spot. All right, if not, just carry on with the ones in the chat. If everybody's shy today.
Oh, no, they're not shy. So I think we've been really good with time. Okay, yeah. So
I think Bumi is here. Yeah.
Yeah.
Sorry, it was my daughter. Now ask your question.
My question was, do people with asthma suffer, or do they continue on with their life?
Are they able to live a sort of what you would say was, do we say, a normal type of life?
I think that's what she's trying to say.
Is that what she's trying? Okay.
Yeah, she has a friend that suffers from asthma.
Do they suffer? Yes, they do. They do suffer.
Sorry, can I just interrupt? Sorry, it's not suffer. They're living with asthma.
They're living, okay, but they suffer from the symptoms, if you want to put it that way.
They're living, yes,
so they are
please.
living with it, but like she said, what kind of life are they living? You understand? Are you living a life where you're going to the hospital every day, to the emergency room, where you can't play with your friends, you can't swim, you can't climb the stairs, you can't, even go for sleepovers, because we don't know, they may have a lot of dust in the other house and all that. So because, sometimes you can avoid as much as you can, but many of these triggers we've said, you can't see them, you don't know. And that's why, your friend would have to be on an inhaler to help her. And if she's using an inhaler very well, most of the time she'll be able to. So the inhaler helps her not to have those symptoms of cough and all those things that make her tired and, doesn't allow her to play. And then when she's using her inhalers very well and it helps, then she's able to do all those things and live a normal life and not have the symptoms.
Thank you for answering my question.
You're welcome.
All right, so I think I have gone through. Okay, no, Olaiwola is asking, does one outgrow asthma? I think this was covered yet. Yeah.
So I know this is a very big, it's a big question, that everybody keeps asking. And it's because of their experience. A lot of people have told me that they used to be asthmatic when they were in school, in primary school, secondary school, and now they don't have symptoms anymore. So, in their mind, that is outgrowing. So like I've said, you don't outgrow asthma as a disease, but your symptoms can get better to the point where you don't have them anymore, that it almost seems like as if the asthma has gone, but your DNA, your genes still remain the same. And that tendency to, to react, that tendency to respond excessively to, all those triggers we've said still exists. And if that's the only thing that anybody remembers today, please remember that asthma doesn't go away. It can get better, but that tendency to react always remains.
Okay, so we have quite a number of factors at play, both genetics and environmental factors with asthma. I think I saw Josephine raising her hand earlier. She has a question.
Yeah, can you hear me?
Mm-hmm. Yes.
Okay, I just want to ask Mrs. Lawal, being in the community, I don't know how the level of the community, because there are different levels of community, like my own experience in Nigeria, there are tertiary, there's really going to the grassroots or the middle class. When you know, I mean, with my experience, this is what I have experienced physically. Some people that I'm glad that she put it on. I'm happy to hear the traffic lights. I've had experience before that. Some of these patients, even when they are at the level yellow, they are already taking a medication called aminophylline, IV. And who are the group to be blamed in the medical settings? It is the so-called the people that call themselves pharmacists. So I don't know what they are doing about that, because it's a big problem. It scares me. It's very, very, I feel so concerned, for them to be taking, and there are some sets of people also in the medical settings that say they are nurses, And they are the people that give them this aminophylline IV. So it is very, very scary. This is something I've experienced, I've seen physically. Not one, not two, not even three. So I don't know how they can take care of the people in the real, when they talk about, community, the people in the grassroots who suffer this, who are kind of in this group, this group of patients, like asthmatics. The knowledge is not there at all. So I don't know how we can carry this knowledge to the grassroots, for them to know that aminophylline is something that you must not play about. And another thing I discovered then was, in fact, they have a nickname for a medication. They said it's called 3-in-1. I don't know whether they still practice that. Somebody is in kind of a condition, an asthmatic attack, and maybe they come back from the farm and they are having this, which I feel that time must have been allergic situation, and they just send their child to go and buy 3-in-1 for them. There was a day I asked, what is this? What is actually in this 3-in-1? They mentioned it to me. One of them with the prednisolone, paracetamol or ibuprofen. Then it's either followed by one antibiotics or the other. So it's scary. I don't know how, because I know it is still happening, but what can we do about it? And another thing I want to mention is when one of the speakers talk about that I think is Mrs. Lawal, that they don't have knowledge of what their children are having. I know that happens every time. So one thing I discover is that the pharmacists, they feel reluctant to give the prescription to the patient or the family member. Why? Because of the problem of them thinking that they will go and buy the same medication when they have the same symptom next time. So this thing is a cycle. It's a big problem. Thank you.
Okay, so we've had quite a number of issues there about, outreaches, community education, sort of behavioral issues as well, self-seeking. So it would be good to hear from our speakers about maybe your thoughts on possible solutions. And I'm happy that you're part of this program because you're already doing something which is educating the everyday person and hopefully some healthcare professionals. So what are your thoughts about some of the concerns that our participants has raised? What do you think we can do?
Can I start, and then Ms. Lawal can say more. I think this is not only in Nigeria. What you've said, Madam, is not just peculiar to asthma. There is a lot of illiteracy when it concerns medical conditions, and I think the government at a level, for example, when it comes to simple things like even signs of a stroke, where I live in the UK, is information that the government has put around. A lot of people would know what the signs and symptoms. What the symptoms are. So when somebody has that, people around him can help. Things like CPR, most people are trained to do CPR. So in Nigeria, so this is a big problem, because from the government to the healthcare professionals to the patients, there are failings on every level. Some people will see there are doctors there, but they won't go to the doctor. They will go to the patent medicine seller. So the problem is very endemic, and we hope that as time goes on, there will be especially with the way that the internet has become very, available, that people can actually access very good information, not just because on social media you have lots of misinformation as well, and that's why I wanted to tell people about Asthma Long UK website. It's a trustworthy website. People can go there and read about things for themselves. So the problem is not just about pharmacists or doctors, but is a multifaceted problem. Our system needs to be upgraded, the healthcare system in Nigeria. And except we get to that place, we still have a lot of these problems going on. Thank you.
Thank you very much, Pharmacist Callista. So multifaceted issues and quite a diverse number of solutions that need to be put in place. Dr. Yesterday, your views, please.
Okay, thank you very much, Josephine, for those observations. So just as Callista said, it's a huge problem that it needs a whole big overhaul, because sometimes you can't even blame the people. For instance, that 3-in-1 that she was talking about, somebody must have prescribed it for somebody. There's no way that farmer would have known prednisolone. I can't remember the other 2 things that they mixed together. Somebody must have done that. And just because probably they know that prednisolone works for asthma attack, then you add, just in case it's infection, you add antibiotics. Just in case it's heart failure, you add Lasix, and you mix everything together. So, there's a lot of, poor, fine, there's a lot of illiteracy amongst the people. But the problem we have in Nigeria is that when they now even get to the people that are supposed to help, so the so-called pharmacy, which may not even have a qualified pharmacist, it's not everybody that wears white coat in Nigeria that is a healthcare provider. It may even be a cleaner in a hospital that will open, a clinic, and everybody in the environment would think that the person is a doctor. So at least, so there are different parts of it, and a lot needs to be done. First of all, educating the people as to what are the signs and symptoms, and then when they now get to the hospital, also the training and retraining of health workers to know, what to do and what not to do, and then also legislation in terms of prescription, having to take a prescription to a pharmacist before you can get medication. So if all that is not done, then all these things will still continue. Because the issue of the aminophylline she spoke about, in the past, that was what we needed to do, because we didn't have all these inhalers we're talking about, were not easily readily available. When I was in medical school, there was nothing like all these inhaled corticosteroids. It was, all we knew was aminophylline and maybe nebulized salbutamol. So a lot of people are still stuck in that old, way, and they've not been retrained to know that nobody, before you use aminophylline, it's like one of the very, very last things you would do. So we'll keep doing what we can do and advocate, for, and keep educating. One person tell the next person, and then as the information keeps going, then we hope that things would improve. Thank you.
Thank you so much, speakers. So we have a question from Stella Otu Ekong. She would like to ask a question.
Stella, just raise your hand so I can find you and ask you to unmute. If you have a question. If not, let's move to the next person.
All right.
Okay, here we go. Here we go.
That's not Stella.
Well, they've raised their hand. Let's go for it.
Okay, because we had some people earlier. Could you just hold on, the person with the Huawei phone, I think. Is that how to pronounce it? So Pan-Africana Strategic and Policy Research says, thanks to all the presenters and organizers. In case you are with someone who suffers an attack, so an asthma episode, what first aid can one give?
Yesterday, Callista?
Okay, thank you for the question. Okay, let Callista.
Usually, I'll just say one thing. Usually, the first advice we would give is to the reliever to use the blue one. That's the fast acting one, and that's one that can help to open up the airways. And so that should be used 2 puffs and the maximum the person they can use, but you just keep after every. So you use. I think I put it in my slide. So the person can use 1 to 2 puffs, and then give some time. I think about let's say about 30 minutes maybe, or I don't want to say give the wrong information. Let me say, Dr. Yesterday, you don't deal with this, but I know that salbutamol is the right one to use.
Yes, yeah. So at least that's the first step. You do the 2 puffs and watch, for response. Sometimes that may be all you need to do, but sometimes when it's a very severe, so if the person is having acute severe asthma, which is the one that is not going to respond readily, then you may even give up to 10 puffs. So 1 puff every 30 minutes to every 30 seconds to 1 minute. You can give up to 10. And then after 15 minutes, you can repeat that again. But by the time the child is at this level, then you should start making your way, to the hospital. But at least this is what you can do before and, on your way. And it also depends on what is on your, so that's why we're talking about the asthma action plan. Usually, the person should have been given steps of what to do. And if the person had been given, some patients, depending on, on how knowledgeable they are, you may actually give them a dose. You might have given them a dose of prednisolone to use, as a start dose while making their way to the hospital. So, but we know that this asthma action plan we're talking about, even in my clinic, which is supposed to be tertiary, we know that many patients don't get this. But at least if somebody has an attack beside you, that's what you can do. And if they don't have, the Ventolin inhaler, somebody can quickly go and get it. But the important thing, that's why I keep saying, just start going to the hospital, because if you don't have an inhaler at home, there's really nothing you can do but to go to the hospital as fast as you can.
Okay, thank you very much. So I'm just going in accordance with how people asked your question. So if you've raised your hand, I'm going to call you in a few minutes. Just be patient, please. So Scholastica Eju said, what's the difference between asthma and bronchopneumonia? And another question was, when a child is declared asthmatic after being when a child is declared asthmatic after being diagnosed of bronchopneumonia, what is the difference between asthma and bronchopneumonia?
Okay. So like we said earlier, so asthma we said it's mediated by, allergic, inflammation. So it's an inflammatory condition. So it's the allergic pathway that usually leads to that. So somebody is exposed to something in the air or something they ate or whatever, and then the person now starts having the symptoms. So that is what asthma is. And the symptoms are usually recurrent. It's a chronic condition, something that is long lasting. Whereas for bronchopneumonia, it's an acute condition. It's a respiratory infection of the lungs. So it can also come up with the same symptoms that we've said, cough, all those symptoms that the person with asthma has, they can have. But in addition, the person with bronchopneumonia would have things like fever that would, point to an infectious cause. And so, but the confusing thing sometimes is that somebody who has asthma and now has bronchopneumonia, the infection can trigger an asthma attack. So the person can actually have the 2 things together. But the way to just differentiate it is that anybody can have bronchopneumonia, but asthma is for specific people with certain risk factors that we've mentioned. And somebody who also has asthma can have bronchopneumonia. So asthma, chronic, bronchopneumonia, acute. Asthma, inflammatory, bronchopneumonia, infective. It's caused from an infection, either viral, bacterial, fungal. So many organisms can cause bronchopneumonia. I hope I was able to answer the question.
Okay, thank you. I hope that was okay. That was from Scholastica. So next, Stella Ekong has been waiting for a while. Please go ahead and ask your question.
Stella, I'm asking you to unmute. You can unmute yourself, please.
All right. Good evening, everyone. I really appreciate this. Yes, I learned so much about it. I have two questions. The first one is, I wasn't here when we talked about the red flags, the traffic lights. So I need to get a little information about it. And then secondly, I got the two inhalers for my son, the blue one and the lilac color. So yeah, when we initially got it, I was told how to use it, but I think my child didn't really have the attack like frequently, so I kind of forgot how to use the inhaler. So please, could you educate me on that as well? Thank you.
Okay, so Calista, well, anyone can go for that, but I think Mrs. Lawal is back. She talked about the traffic lights. She just wants to just summarize that again quickly. Mrs. Lawal?
Hello.
Yes, please
So
go.
sorry, I'm getting ready for a clinic appointment, so I'm just trying to hurry up. The traffic lights, well, I did say that the green shows that there is control, and whatever is being done to get that control should continue as prescribed by the doctor managing. And then amber, that's the amber light, shows that we are getting out of control and we need help. So the person can reach out to the pharmacist or healthcare professional that is close to that person for help. But once it gets to the red flag, that's emergency. That person has to get to the hospital or call the doctor immediately. So basically, yes, that is what I explained. But then there are more nitty-gritties into it. And like I said, it's personalized. So it will be nice if you see your pharmacist or doctor to look at it in more details as it affects you.
Thank you, Mrs. Lawal. Yeah. What was the second question, Stella? Could you just repeat your second question?
Sorry. Before she goes, can I just mention something? With this traffic light system, there's a test called the asthma control test, and that is what gives this traffic light system. So you can actually get the document online, but what it checks is that it checks in the last 4 weeks the patient's symptoms. So how much of their sleep is affected by asthma, how is asthma affecting their day-to-day life. So that is how it is scored. And so the score is what puts one in the amber or the red or the green. So it's called the asthma control test. So the score, and that's how you get that. So the questions we usually would say them is, in the past 4 weeks, how much of your time or how much of the time has asthma affected your, maybe for school or work? In the last 4 weeks, how often have you had shortness of breath? In the last 4 weeks, how your symptoms, the wheezing, the coughing, shortness of breath or chest tightness, woken the person up at night? And he has a score of 1 to 5 for each question. The fourth question is, in the last 4 weeks, how often have you used your rescue inhaler? And really, the more frequently somebody uses their blue inhaler in a day, in a week, then that means that person's asthma is becoming bad. Usually we say if you get to use it more than 2 times in a week, then the person needs to have a review with their doctor to see what is going on. And then the last question, question 5, says, is just for a person to particularly rate their own asthma. When you say the person, how can you rate your asthma? So it's called the asthma control test, and is what is part of how you can assess and see what whether it's green or amber or the traffic light. Thank you.
Thank you, Ma. Sorry, I also asked that the difference between the blue inhaler and the lilac color, because I bought it too.
Okay. So from what you have said, I would imagine that the lilac would be probably Seritan, but I can't be sure. But it may be good to go to a pharmacist, and the best really would be to go back to the prescriber, because like Dr. yesterday said, each patient is different. Some people will be prescribed just one puff because they have mild asthma. Some people may need to have 2 puffs of the particular. If you remember that each inhaler has a strength, just like how you have ibuprofen, 200 milligram, 400 milligrams. So when it comes to inhalers as well, especially the preventers, they have a particular strength. So you have 50, you have 50, you have 100. So it depends on what it is. So it may be good to go back to the prescriber and then let them, tell you what it is that they want your child to be taking.
I was told that the other one is for prevention. Does it mean the child has to take that like every day?
Okay. Sorry, okay, maybe you missed that bit. Yes. So for the preventer, which in your case or in your child's case is a lilac one, it's supposed to be used every day, and that's why it's called a preventer. If you followed what Dr. Yesterday said, asthma is more of inflammation going on in the airways. So using the preventer every day helps to prevent that inflammation from even starting. So it keeps it at bay, and the person can then live a normal life. The blue one is the one that we encourage asthma patients to go around with on their person, so that if at any time any of those triggers begin to trigger a response, to cause inflammation, they can quickly reach for the blue one, use it, and it gives them a relief there, and they can begin to breathe better. So that's why we say the blue one should always be on that person, and then the preventer is used twice a day. And if they begin to use the blue one more than 2 times in a week, then they need to go back and review with the doctor. Especially if they're using the preventer daily, then something is going on and they will need to be reviewed.
Thank you so much. I really appreciate your responses.
Okay, so please, can I step in a bit? Because because you said your child had been prescribed that some time ago and you can't remember what was said. So my advice, because you don't know what has happened between then and now, the child needs to be reassessed and to be sure whether the dose that was given then is still what is required now, and so that the child can start using it. And I would advise that you follow up. So anytime a child is prescribed a medication, it's not just a blanket prescription. You usually say use it twice a day for probably maybe a month or 2 months and see me, because sometimes we actually reduce it. So if we reduce it to once, we may half the dose, we may add another drug, we may stop, there are so many things, and it has to do with the monitoring. And just as Kalisa, thank you for that. So the asthma control test, these are things that when you come, we'll see, are you well controlled or not? And then we'll be able to, adjust your medication. So I don't think you should just start using it, twice a day. We don't even know the dose of what you are using. There are many different strengths of the lilac one. There's 25/50, there's 25/125, there's 25, so I think you should go back and get your child reevaluated, and then the prescription written again. Then we can now take it from there.
Thank you.
Right, thank you very much. So the importance of continually reviewing our health and those of our kids. So over to Feyi Shade. Your hand is raised. Please go ahead and unmute to ask your question.
Okay, good evening. Good evening, everyone. Okay, yeah, so I grew up being asthmatic, but after a while, I outgrew the condition. But when I had my son, I noticed that he started having this wheezing, right? So then the doctors would prescribe Asthmaline and all that for him. But I wanted to find out. So growing up, we had this, I don't like to self-medicate. So I was just thinking there were things we used when we were growing up. So my brother and I were asthmatic. We used this tiny medicine, Ventolin, the lilac one is very little. We used Franol. And then when the condition was severe, I knew that my mom, who was a doctor, had either adrenaline administered on us, and all those things. I just want to know, I heard you mentioning aminophylline. I don't know if they still have them, but I want to find out those Franols, those Ventolins, which I used to carry about in my bags to school, not the inhaler, but the tiny tablets. Are they also still available instead of the inhalers? Can the kids carry that, because they actually worked in those days? So I wanted to find out what are the differences. Why do we prefer the inhalers over the tablets? Thank you.
Yesterday.
Okay. Calista had mentioned a bit of that earlier.
Okay, was it in?
Yeah. So, in those days, like I said, most of all these medications we're talking about, which have been in existence for over 20 years or more, were not readily available in this part of the world. And so we had to use what we had to use, even though they were not effective. And even though we say they were effective then, you had people who had, I remember, I don't know if you had any friends who had asthma then, that their chest was always, we call it the barrel chest, their chest was always like, wide, because they were probably in a state of constant, obstruction, and they just used to manage. So it would seem like they were fine because they were not having attacks all the time, but they couldn't run, they couldn't, do you understand? They couldn't, I remember then they couldn't sweep, they would say they should go and stay somewhere, all those kind of things. So they were not really, effective drugs. And so now that we have more effective drugs that don't have all those side effects, because for instance, the Ventolin tablet that you're talking about is used in ONG to stop contractions in women, to stop premature contractions in women. So it's a drug, once you take it by mouth, it goes all over the body, and affects other organs. You sometimes when you use Ventolin, you see that you start having tremors, your hands will start shaking, the children start getting restless, they start running up and down, and all. So all those side effects are more with the tablet and the syrup. And so we say all those Asthmaline and all that, when there's something that can be used in minute amounts that is going directly to where it's going to work, why do we want to use another mode? So it's not like the oral is not going to work, but it's going to have other side effects that you want to avoid. So, and that's why we're using, these. So it's not like they are new. They've been in existence and used in other parts of the world for a while. It's just because they were not readily available in Nigeria. So I hope I was able to answer your questions. So your child can still carry their Ventolin in their bag, but the inhaler.
Okay, thank you very much. So we've got a question for, just one last question from Ezinwa. And Ezinwa says, how early in life do you advise that a child should be told they are asthmatic? When do you think you should let them be involved in their management?
As early as they can, as the diagnosis is made, if they are able to understand what you're doing. Of course, a 3-month-old or a 6-month-old who has been diagnosed with asthma, obviously how involved, but a child from as early as the child can know that when I can't breathe, I reach out for this my thing that has a mask on it. Do you understand? So as early as they can understand, begin to tell them that if they are not feeling okay, they reach out for, I remember my kids used to call it bubble. I used to say when they are using the spacer, I would say blow bubble, and the spacers usually have like pictures of like cartoons of a lung on it and all that, just to get the children, not to be scared of it and things like that. So as early as they're able to understand, let them know. And then you will find, I have some kids who would, when they go to parties, they ask, is there any egg in that? Maybe they want to give them cake or something. Say, is there any egg? Is there any nut? Is there any, they'll be asking all those questions. They'll say, no, I can't have it, because they've been told that if they eat something that has nuts, that's what is making them not breathe well. So as long as the child is old enough to know, let them, get involved and know, because they may be somewhere at a party or somewhere where you are not, and they are the ones that will be able to let people there know that this is what I use when this is wrong with me, or, or that I have asthma and I need my inhaler. Okay.
Great, thank you so much. So we'll take our last question after this question, we'll invite Pharmacist Flora to bring the event to a close. So we're going to take a question from Itunu. If you had a question, I would suggest that you type it in the chat, and we can also always send you an email later because we have to close. Sorry. So Itunu, please go ahead and ask your question.
Okay, so my question is this. I'm an adult and I now have asthma. I've had it throughout childhood. As a child, I was able to identify what were the triggers. So dust was a very big trigger for me. And I'd say probably like in my 20s and 30s, my asthma was very well controlled and I hardly had asthma attacks. But in my 40s, I've realized that it's like nearly every other month. What tends to trigger the asthma is a cold, so like a viral infection. So gets a cold, and the cold for some reason will always end up in my chest. And I have all the symptoms that were described except for chest pain. I don't have chest pain, but everything else. I was just wondering, I've had a review. My medication has been reviewed, it's been altered, but I still tend to, every other month, I end up having to sleep upright at night because of the asthma. So do you have any advice, please?
Okay. Sorry about that. So just as we've said, so you've identified, that it's usually associated to when you have a cold. But at the same time, there may be something else, within the home, that may be making it to, making the asthma worse. And so you may need to try to because it's like a kind of investigative work, because even if your medication is changed or increased, if your trigger is still there. So if there are things that are modifiable and there are things that are not modifiable. So the modifiable one is the one you can do. So all the things we've spoken about, mold and the dust in the house and all that, changing the sheets, using allergy, using mattress covers and things like that. So there may be something that has changed, that is making it worse. And then I don't know if you moved house. So these are all the things, because you may be living maybe in an area that it has more air pollution, for instance, and all that. And so if you've looked around and there's really nothing, you've done what you can within your home and it's nothing, it's something from outside, then it's just to keep monitoring your peak flow, and then your medications will also need to, so they may need to add something else, to it and all that. So it's difficult really to say, but what I would say is all those things I said about the home, the indoor, all the mold, dust, and cockroaches, or anything that you can do, within the home, because that's where you spend most of your time. And then it may be something at work, so it's just to try to just cast and see, since there's a specific time when it started getting worse, then maybe something had changed. But it may just be nothing. It may be your hormones. Like I said, adult onset asthma is more common in women around that 30s, 40s. So so if there's not, you've done everything you can about the home and there's not, then with your doctor, then they may need to keep adding or adjusting your medication until you're able to get the one that would give you that control that you need. Thank you. I hope I helped to answer question.
Thank you so much. And thank you to every one of the participants who have interacted during the event. I know Speaker Kalista wants to say something, so I will, please go ahead, and then Francis Flora will round up the program. All right.
just want to add something to what Dr. Yesterday said for the last speaker, because it depends, because if the inflammatory process has been triggered, and that means that, so when you say your medicines have been reviewed, so it depends on what it is. So maybe also be a case of having to use the preventer here, like maybe a higher dose to get it back to, to form, and then begin to maintain it. So it depends on what inhalers or what medicines that your prescriber has also given you. So it may be worthwhile reviewing that as well, in addition to just doing what Dr. Yesterday said. Thank you.
Okay, over to you, Pharmacist Flora.
All righty. Wow, thank you so much, everybody. I want to say special thank you to the speakers, Dr. Yesterday, Fam Calister, Fam Lawal, and of course, our very able moderator, Dr. Orode. Thank you so much. I really appreciate your time, your effort, your input, and your sharing of your knowledge and experience. And I want to say thank you all once again for joining. Thank you for participating. Please remember to share this knowledge with people. Don't just hold it for yourself. Share what you've learned. And we will see you in April by God's grace. Thank you so much. And don't forget, if you want to know more about our blood test service,